Ladies and gentlemen, a very good afternoon. So let's start. I'm especially delighted to welcome Helen Kohlen to present in our Ethics of Care series. This is the 6th talk. On short notice, Helen graciously agreed to do today's presentation after Catherine Galvin and Christine Rumery couldn't due to health reasons. And of course, we want to wish both of them a speedy recovery and all our very best wishes. Thank you, Helen. This is much appreciated. Helen Kohlen is Professor of Care Policy and Ethics at the Faculty of Nursing at the Philosophical University of Vallendar in Koblenz. And she's also affiliated to the University of Alberta in Edmonton. And then, of course, also affiliations in Mexico, and she works with Franz and Andries at the University of Humanistic Studies at Utrecht. And her own studies started off in Hanover, where she got her doctoral degree in political science, and she specifically focused during that time on biopolitics and its effects on practical arenas in healthcare. Currently, her research focuses on transformation of care practices in medicine and nursing. And in view of the Francis report, also quite important for the UK setup. Currently, she's also investigating end-of-life care practices in intensive care settings. And it's a comparative study with an array of very interesting countries, England, Ireland, Brazil, Palestine, and Germany. So she did transnational research on hospital ethics committees and design caring committees together with clinical practitioners in several hospitals all over Germany. Helen, most welcome. And she will address the topic bioethics and conflicts of care in the hospital arena.
So thank you very much for the introduction, and thank you very much for the invitation to be part of this seminar series. My talk is about bioethics and conflicts of care in the hospital arena, and how care ethics and bioethics cannot serve nursing issues. This paper begins by situating the development of hospital ethics committees within the discourse and practices of bioethics in Germany, and by offering next a critical review of its history in the US and in Germany. While a discourse on autonomy and principle-based ethics has dominated in the field of bioethics, care ethics and the language of care got rather marginalized. Findings of my field study in Germany that investigated into concrete practices of hospital ethics committees reveal that a focus on autonomy reduces the language in such a way that issues of care and conflicts are rendered invisible. So, I'm sorry, this is a little bit different from what I did yesterday. So, after my introduction about transformation of care practices, I will come to the German context. Then I will talk about the history of hospital ethics committees in the US and Germany, and turn to the dominance of the 4 principles and the critique that has mostly been presented by feminist care ethicists. Then I will turn to care ethics in the clinical field as a kind of a counter movement to the autonomy-focused bioethics movement. And I will give a look inside committee discussions by presenting one example. And I will sum up everything and do concluding remarks. In Germany, Along with the processes of healthcare reforming, modern bioethics as a discipline as well as a practice has become established within the last 15 years. With regard to burning issues, one impulse for the evolution of applied ethics in German healthcare arose from a widely spread discourse on reproductive technology, gene therapy, embryo research, or intensive care at the end of life. In the dark light of German Nazi history, end-of-life care issues have been an incessantly crucial issue of bioethical discourse in Germany. Since 2004, end-of-life care practices have become a dominant pointed issue by governmental committees within the context of the use of living wills, and currently on a new law that should regulate assisted suicide. The fact that difficult end-of-life questions are answered by a demand for written forms of living wills to secure patients' autonomy is one remarkable change in medical and nursing practice. In fact, that the debate on the use of living wills prompted governmental intervention and that living wills became statutory in 2009 refers to a remarkable transformation. Care practices at the bedside have never been regulated by political authorities before. The regulations are now increasingly discussed by hospital ethics committees. Within the context of bioethics, these hospital ethics committees are institutionalized forms of bioethics qua practice. They can be seen as a part of a process transformation, the phenomenon of what René Fox has called the bioethics movement. Rothman analyzes this move as a history of how bioethics has transformed clinical medical decision-making. So I've already now turned to the historical aspect and the people who talked about this kind of transformation that is taking place. I use this hospital ethics committees as a unit of analysis to see what is happening within this framework of bioethics that has turned into or come into the hospital arena. And by seeing the historical part, the development of these committees and what they picked up from the framework of bioethics, I then analyzed another movement by asking, were there any other discourse going on in the 70s and 80s that were not coming into the light as bioethics was? And then I could see, oh, this was also there, but it was rather in a minor position. This is the relational analysis I did in this work. And then from this background, having this in mind, how bioethics moved on into the practical arena and situated itself in this analysis, in this unit of analysis, hospital ethics committees, I went into a field study and I observed in three hospitals, the ethics committees. I took part in these meetings and observed the discursive practices, and I could see what they were talking about and not talking about, having this movement in mind and the dominant discourse. So this is the methodology behind. So the historical analysis, the question here was the movement of bioethics into the hospital arena and the development of these committees, local committees, the language used in the committees as a discursive and as discursive spaces, the relational analysis, what were parallel movements in the field of ethics, what were minor discourses. Then the practical one, which languages are used by whom, which terms are and are not accepted to frame the ethical problems. And I did a focus on nurses' participation. So the term bioethics came into use in the US towards the end of the 1960s, and bioethics, like the field itself, was initially intended to represent a broad-based multidisciplinary field. The main intellectual actors and professional participants in US American bioethics have been philosophers, theologians, physicians, lawyers, and biologists. And I will go back a little bit, because this means that they had already, from start off, coming together from different disciplines, they had to find a language where everybody would understand what they mean, but would no longer stick to their discipline. In the 1970s, hospital ethics committees were created in the US, not only in order to discuss ethical research questions, but also problems in clinical care. Besides taking responsibility for staying informed on major bioethical issues with clinical relevance, like regulations of living wills, hospital ethics committees serve to develop, review, and apply the policies in and of the institution. In hospitals, the most common form of ethics policy is the do not resuscitate policy, which sets out the institution's guidelines for withholding or withdrawing life-sustaining treatment. Moreover, hospital ethics committees are responsible for case review. The kind of review varies. The committee can be directly involved in prospective case reviews and becomes a consultant to assist in the ongoing management of care of patients. Committees do usually also offer retrospective care review. Then the goal is to determine whether and how the case could have been better coped with. So, like somebody wants that something is discussed because something went wrong, they can discuss the case, and then they say in the end, so what should we do the next time, and what can be a better way of consultation. And usually they end up that the structure also is very important to have a look at and to see in which way they can find solutions for structural problems. In addition, these committees play an educational role. Education especially involves the training of a special model of ethical decision-making in order to discuss an ethical issue reasonably. With regard to actors, such committees consist of small groups of people, professionals as well as laypersons, who meet on a regular basis to address the so-called ethical issues that emerge within the healthcare institution. Personnel-wise, a hospital ethics committee is composed of physicians, nurses, social workers, hospital chaplains, as well as one expert on ethics. Among them, there is sometimes a lawyer and at least one person who is in the position of being an ethics expert, usually a philosopher or a theologian. The group is acting behind closed doors at a special place and time, and may serve themselves, the patient, the relatives of the patients, a special unit, or the entire hospital. In the 1970s, especially due to Karen Quinlan's story made public by media frenzy, modern ethics committees development took off. Based on the diagnosis irreversible brain damage, and by New Jersey Supreme Court's request, physicians constituted an ethics committee to clarify whether the patient should be kept alive artificially or not. De facto, it was a prognosis committee consisting of physicians playing an exemplary role of defense against legal pursuits. In the following years, also offering moral relief concerning unpopular decisions. In 1978, additional precedents motivated US Congress to constitute a President's Commission for the Study of Ethical Problems in Medicine. For a duration of 3 years, the commission, consisting of 10 people, should address problematic settings in clinical practice. Congress desired field guides as well as ethic guidelines and legal standards were published in reports. The report on therapy limitation regulations also contained a clinic ethics committee's task description. In order to introduce different perspectives to decision-making, a committee consisting of various professions were highly recommended. The committee explicitly was declared an alternative to legal proceedings as, concerning matters of life and death, going to court should be the last option. A few years later, more than half of US hospitals had ethics committees. In the 1990s, mandatory establishment of ethic counseling was promoted by quality management accreditation procedures. And what I identified is the development of these committees in Germany turned out to be a remake of the US American one. In Germany, hospital ethics committees' potential as a new, attractive moral institution was first discovered in 1997. In a shared brochure, the Protestant Hospital Association and the Catholic Hospital Association were calling on their institutions to build up ethics committees based on the American model. Due to the introduction of quality management and accreditation procedures in hospitals since 2003, also in Germany, establishment of ethics committees has increased drastically, as it was the case in the early 1990s in the US. In addition, similar to the US, German doctors' representatives called for a formulation of applicable standards for these ethics committees, explicitly favoring extensive institutionalization. I will now turn to the dominance of the principles with the focus on autonomy. To this day, the Principles of Biomedical Ethics by Tom Beauchamp and James Childress constitutes the key textbook on medical ethics. The medical sociologist Barbara Katz-Rothman remarks, "It would be impossible in the US context, and I also think in Germany, to discuss bioethics for 5 minutes, let alone for several hundred pages, without bringing up Beauchamp and Childress and the 4 principles they use to discuss bioethical decision-making. This approach to bioethics that has become so widely used as to is almost a paradigm itself. Every decision, every conflict, every ethical discussion can be placed on a grid of the 4 principles: respect for autonomy, non-maleficence, beneficence, and justice. But like a well-worn joke, the punchline is clear. As soon as the setup has been made, each principle will be considered and autonomy will be decisive. A variety of reports on ethics committees operating procedures by using the principle-based approach stem from the 90s. In her field study, Patricia Flynn found out if it comes to decision-making, committee members sing the principle of autonomy like a refrain in the choir. There's a pattern of talk in these committees, she identified in her field study. Dealt with ethics at all was to present the case, and someone would say, what is the ethical principle? And another person would say, as in the mantra, autonomy. The incantations of justice, autonomy, beneficence, veracity, and fidelity were heard throughout the committee. The chair would press for two ethical principles that were in conflict so that the response might be, for example, autonomy, and he would ask verses, and someone would sing out justice. So when we look at the critique with regard to principle-based ethics in hospital ethics committees, we find Margaret Urban Walker, who developed her theory of moral understandings and also stressed the importance of carrying responsibilities. And she thought about this and asked the question, aren't as abstract principles often given sometimes new meaning under the impact of concrete cases rather than cases being simply decided by the application of principles? And who or what decides what is a case, a moral problem in the first place, as well what sort of case subject to what principle or principles it is? To sum up the critique, the use of principles in committees is in danger to become an engineering model that supports a way of dealing with cases and framing questions in a technical way. Hereby, narratives that show the context of situations might get excluded, conflicts that do not fit the model can be marginalized, as I will show later on with regard to care and caring conflicts. Solot Dorman did a study on this and found out whose voices are mostly heard and valued in discussing issues of concern in patient care is dependent on the hierarchical setting, like the hospital. Profession, rank, and degree often determine the extent to which permission is given to speak freely and authoritatively. That is also a study done in the 90s. She concludes by saying, women tend to occupy less verbal space in conversations and need greater and often specific encouragement to speak their thoughts aloud, and nurses are the ones who are more likely to hide their ethical concerns. Am I doing fine with time? Yeah? Okay, now the parallel movement that was going on in the 80s. First of all, let me sum up my reflections when I was coming to the solution how powerful bioethics with a focus on autonomy is. I asked myself, so what does this actually mean for the Hippocratic Oath and for nurses who are so much working in caring practices? Looking at the roots, however, nursing and medical ethos is an ethos of care. Medical ethos is based on the conditio humana, with the aspect of interrelated human life preceding autonomous life. Especially children, needy, sick, and old people depend on care. The Hippocratic Oath includes 2 of the 4 principles of modern principalism: beneficence and non-maleficence. Autonomy is not mentioned. In the 1990s, separately to the history of bioethics and the favored model of principalism, care ethic approaches developed. What they have in common is the highlighting of practices, the relevance of power relationships, inequalities, and conflicts were especially included in political care ethics theories by John Tronto, Elizabeth Conradi, whereas Margaret Urban Walker's philosophical approach puts a clarification of responsibilities into focus. At this time, I need to explain a little bit more about my methodology, because, of course, when you do field study and at the same time historical study and go into care theories, you do not do that one after the other. You do that at the same time. So when I was reading these care ethics approaches, this could help me when I was sitting in the ethics committee, what they were not talking about, and all of a sudden I could realize, well, they are not talking about a clarification of responsibilities here. They are not talking about very concrete care practices. Care, thought as a practice, is alternative to conceiving care as a principle or as an emotion. Calling care a practice implies the involvement of thought and of action. Thought and action are interrelated and they are directed toward some end. This is Tronto. Agreeing with John Tronto, I understand care in the clinical setting, in the restrictive sense, to refer to care when both the activity as well as the disposition of care are present. Tronto and Berenice Fischer have identified different phases in order to understand the necessary dimensions of care. As an ongoing process, care consists of 4 interconnected phases that can be analytically separated. In practice, they will come together and not be so easily separated. It's caring about, and it means attention to the need for care. Caring for is assuming responsibility. Caregiving is the practical attention to and satisfaction of need and needs. Care receiving is the response of those obtaining the attention of care. And for me, it was very helpful to have that in mind when I was watching how nurses were trying to describe the practices and not giving attention to describe it so concretely within a framework of care ethics. I'm not putting blame on them because at that time the principle-based model was taught to the people in clinical ethics and not care ethics approaches, and not the language was picked up. From these 4 elements of care, Tronto develops 4 ethical elements of care: attentiveness, responsibility, competence, and responsiveness. Care, of course, is not always a well-integrated process, but care involves conflict. While ideally there is a smooth interconnection between these phases, in reality there is likely to be conflict within each of these phases as well as in between. I will now give you a look into the committee discussion by giving one example. And if we have time, I could give you another example. Again, I quote Barbara Kath-Rossman here. At bioethics committees and conferences and discussions, people start off talking about moral wrongs and end up talking about regulatory oversight. This is also true for my observations during committee meetings. My field research aimed to examine the way caring issues were talked about. The questions I raised: what counts as an ethical problem? Who defines it? Which issues get attention and which ones are sidelined and dismissed? How do the different members of the committee cope with concerns of care, and how much space for discussion is given to them? What kind of questions are raised and what answers are given? Do the attended issues of care change in the course of a discussion and how are they framed? What conclusions are drawn when caring issues are discussed and how are they put into action? Who feels responsible and what are the conflicts revealed in their discussion? The following example is taken from one discussion during hospital committee's meeting. And I called it, the name is A Petit Ethical Problem. Using the warmth of an old patient's belly to warm up a blood bottle. A nurse had written down a concern in order to consult the committee, and this was a retrospective case review. The female minister took the paper to the committee meeting and read it aloud. When retrospective case discussions are done, usually the committee chairperson invites the person who wants to have it discussed to write it down. The nurse had experienced a situation 2 years ago that was still bothering her. An elderly female patient had been in need for a blood bottle. When the blood bottle had arrived from the lab, it had still been very cold, and the physician on shift asked the nurse to put the bottle on the old lady's belly so that the blood bottle would warm up easily for her. The nurse, who did know the patient, could not imagine doing it. The patient had been sleeping and was not in a condition to react at all. The female physician then told her to ask another nurse to do it, someone who would be more professional than her. The discussion in the ethics committee developed as followed. The female minister: this is really uncomfortable to get a cold something on your belly. Physician A: this is absurd from a medical perspective. There are, of course, other technical aids that can help to warm up blood bottles. Nurse A: this nurse feels as an advocate for the patient and wants to take care of her autonomy. Physician A: this is really a mini ethical problem. Physician B: I think the problem emerged from hierarchy. Minister A: I think they have some communication problems on the ward. Physician C: but this is really a petit ethical problem. The discussion ends after some minutes, declaring that this is really a minor problem. The minister explains that she will have to talk to the nurse who has revealed her concern. The female minister asks, what should I tell her? Physician A: you can tell her that she did not do anything wrong within the current knowledge of practice. Physician B: and you can add that the problem had to do with hierarchy and failed communication. Physician C adds, well, the more I think about it, the more I feel instrumentalized by this nurse, because this is not an ethical problem at all. Nurse B: you can tell that she did not do anything wrong, and you can tell her about the possible hierarchy and communication problem behind, but never tell her that this is no or a small ethical problem. The meeting abruptly ends. People rose from their places and left the room. The minister kept sitting there and took some notes. A possible interpretation. The minister reacts first and states that is really uncomfortable to get a cold something on your belly. And this actually collides with a practice of care that does not allow putting somebody into an uncomfortable state for the use of something, respectively somebody else. The lady who is ill and sleeping cannot defend herself and therefore needs protection. Physician explicitly speaks from a medical perspective that this is absurd and that this is not the right way to warm up blood bottles because they are technical aids. This is obviously not a medical dilemma in which physicians do not know how to make an adequate decision. Nurse A shows empathy for the nurse who has opened her concern. She identifies the situation for the nurse who cared for the old lady in the role of an advocate of the patient who wanted to take care of her autonomy. Caring for her autonomy from a nursing understanding could mean that the patient cannot articulate herself and therefore needs protection, here given by the nurse. This is nurse's mandate. It is different from the physician's one who is interested in getting a warm blood bottle for a medical intervention. Nursing care for patients who are sleeping implies keeping her or him in a state as comfortable as possible while protecting them from disturbing noises, interventions that can be postponed, like taking the blood pressure, as well as disturbing and uncomfortable interventions like putting a blood bottle on their warm belly. Although the patient is in a state of not being able to verbally interact, the nurse sees that her autonomy still belongs to her and cannot be taken away. She uses the principle of autonomy to justify her nursing care, namely her responsibility to take care of the patient's sleep. When the physician defines the situation as a mini-ethical problem, without giving any reason, no questions or controversial points are raised. The question why this is only a small ethical problem is left open. The physician does not feel a need for explanation and nobody else asks for it. Then the commentaries that lack of explanation go on. Physician B declares it as a problem that has to do with hierarchy, and Minister A remarks that the problem might be linked to some communication problems on the ward. Since these are exclamations which follow after the non-rejected definition of a mini-ethical problem, one could ask whether hierarchy and communication are categories that can be put under the umbrella of small ethical problems, or whether they are indicators for difficult situations that cannot simply be framed as ethical. Framing them in the context of small ethical problems minimizes their potential for conflicts and understanding the situation in its complexity, which, of course, can harm not only patients but also disrupt professional identities, here nursing care practices. When physician C repeats the remark of physician A that this is a petty ethical problem, the conversation is ended. There seems to be a hidden consensus about how much time should be spent on what kind of issues. That the discussion of the concern does not deserve much time could have been evoked by the minimization of the problem. The minister, realizing that the discussion is ending, asked the rather pragmatic question, what should I tell her? And the first answer is given by the physician, who started to comment on the concern. You can tell her that she did not do anything wrong. He authorizes the minister to tell. Does this mean that the nurse acted correctly according to a medical perspective? What are finally the criteria to distinguish between wrong and right in this situation? And who has the power to define it? Physician B adds that the nurse should be told that the problem had to do with hierarchy and failed communication. What does the message of this information signify? What can the nurse take out of this kind of analysis? This is difficult to tell because there is no explanation. With regard to interrelationships, especially in between different professions, you can narrow down and contextualize nearly everything with hierarchy and communication problems in a hospital. Physician C feels instrumentalized by the concern of the nurse. This is a strong reproach. This is not an ethical problem at all, is the explanation for his feeling. Does a talk of problems which are not defined as ethical ones instrumentalize disputants? Again, it is not clear what counts as a real ethical problem. in comparison to a petit ethical problem, or a different kind of a problem, e.g., of competence in communication. Criteria are not given. What is legitimization to minimize the nursing concern at all? It was the physician who had the power to declare what counts as a real ethical problem and what counts as a petit ethical problem. Nobody in the group asked for an explanation why the problem is declared to be a petit one. Nobody talked about the physician who told the nurse to use the warmth of a patient's body to warm up a blood bottle. What is the physician's part in the story? What can be said about the clinical expertise and responsibilities? Did they behave in a correct manner? Did they possibly think that this might be a petit ethical problem that counts less than the outcome, respectively having a warm blood bottle for another patient in need? Then putting somebody into an uncomfortable situation is justifiable because this serves somebody else. And in this case, even when the patient is not able to reject and silent, the nurse's professional role is to take care of the patient's sleep. The nurse theorist Roper has developed a conceptual framework for nursing practice. One component of the model is called activities of daily life. Relaxing and being able to sleep is one element of these daily activities nurses have to take care of. This involves having an eye on the duration of sleep, times of sleep, day and night rhythm, sleeping quality, rituals of falling asleep, habits, and aids to fall asleep. Knowing the patients involves knowing his or her sleeping habits and knowing what this special patient needs to get the kind of duration of sleep that helps to recover and gives comfort to her, especially when they are in pain and especially when they are dying. The more dependent the patient is due to his situation of illness and disease, the more comfort the patient needs. For nurses, comfort implies a moral stance, clinical knowledge, and the tangible, practical skills in which they have developed expertise. Okay, I will now, up to this point, give the summary of my whole study and then turn again to the caring issues and what is at stake. Because I have some more time. One of the findings is that all the cases that were presented had to do with age, isolation, and caring responsibilities. That in every case that was in some way present. And I distinguished between the cases that were on the agenda to discuss in the committees and the cases that were all of a sudden there to talk about. They were not on the agenda, but then all of a sudden they came up. They were emerging. And the cases that were emerging in all three ethics committees, all the time, in nearly every meeting at the end, were end-of-life care issues. And in these evolving issues of concern, I identified the following problems. They always had to do with a lack of space, so that ministers invented dying boxes. They called it dying boxes. When they were talking about this during committee discussion, I was shocked. I thought, what are they talking about here? Later, I had a meeting with the minister, and then she showed me it was a box with a candle and prayers in it. So they wouldn't have special places for these people. So they would be very flexible to have that box and go to the dying patient. Lack of competencies in pain care and therapy, positions of power versus expertise. In 2 of the 3 hospitals, it turned out that physicians and nurses had not such a good expertise in what would fall under the expertise of palliative care. Have a good expertise in pain control and pain therapy. And what always turned out is unclear responsibilities at a certain time. So when nurses were on night shift and they were talking about patients being in pain, they would not know whom they should call. There were some physicians there, but they were not having the competence in pain therapy. So this was not clear how it's also an organizational problem, I think. If you know there are patients in pain, then you possibly need another physician to turn to in that situation. In 2 hospitals, 2 more questions were addressed: the nursing shortage and palliative care as an answer to the problem. So they were talking about special cases and wanted to do a retrospective ethical analysis, and then all of a sudden people would say, we can talk about this, but we also have to talk about nursing shortage. We cannot talk about special education here if we do not have enough nurses in the night shift. And they would say, palliative care, we have this palliative care unit now, and that is the place, that's the place where people can die better, in a way better, but we need it also for the oncology. We need a different way of dealing with this question and not having now palliative care unit as a luxury, and then we do not have enough personnel on the oncology unit. So they did not really want to go into detailed ethical discussion of cases, but they were asking for structural problems and organizational ones. Okay, now I come back to this. So my whole summary and my concluding remarks about this study was a focus on caring practices. The discourse and practices of bioethics and hospital ethics committees in Germany is strongly influenced by the US-American shape of bioethics and its move into the hospital setting. The history of an ethics of care has developed separately from bioethics, and the language of care has not yet found its way into clinical ethics and hospital ethics committees. The findings of the field study can make us think critically about the way of framing ethical issues. Although the findings are not generalizable, they support the following assumptions. Conflicts in delivering professional care practices are not seen as such. Hence, in trying to framing it as an ethical problem, it is at best seen as a petit ethical problem, and thus minimizing its importance for attention and consideration. Power dynamics in the observed discursive practices operate in a way that responsibilities are moved away from individual persons as well as from professional groups. Their suggestions for solving the problem had not been put into action by the ones who are present, but instead have been answered by starting a second or third working group that should face the problem anew, or by claiming people in the management department to find manageable answers and regulations. Let me explain this. There were, in one committee especially, when there were questions they did not want to deal with it during the committee discussion, they said we should have a working group here. So they ended up not dealing with these conflicts and questions, having 6 working groups. So, and in one committee, one working group should, the chairperson said, you should have a working group on end-of-life care because it was always emergent. Then the nurses and the minister say, we have we have had working groups on end-of-life care now for 6 years. But the structural problems are not solved yet, so we are not going to have another working group. The lack and ignorance of a language of care leads to an insufficient representation of professional care practices, including its values and conflicts. In case care practices are eroding due to insufficient space and time, but also with regard to unclear responsibilities and competencies, there is a need to address these problematic conditions in the first place. While bioethicists may worry about tube feeding, doctors and nurses are looking at problems of ordinary eating. Bioethicists are drawn to new machines and technologies. Nurses worry about the ethics of using the sleeping patient's belly to warm blood. Hospitals clamor for money and space for new machinery and technology. But as one of my observations could show, a card box with a cloth cover that is used for the care of the dying is not an issue. New wings may be built for elaborate new machinery, but in hospitals, and probably not only in German hospitals, but all over the world, patients and families are shunted into corners, even bathrooms for dying. It is the nature of bioethics to trivialize these problems while focusing on new and big dilemmas. And to sum it up in a few sentences, I think ethical conflicts were faced with a technical language, the way I observed it, and managerial procedures to solve the problem. The issues of care were not addressed with the language of care, not dealt within a framework of care ethics, and issues of care were rather marginalized or dismissed. And this accounts mostly for committee participants who attended a further educational class on clinical ethics, mostly nurses. Nurses were the ones who did attend classes and then came back and wanted to use the principal approach. Palliative care physicians and chaplains struggled the most to bring questions of care to a head, and not nurses. The use of the language that frames the problems in clinical ethics should be reflected. Care issues do need a language that describes and represents clinical caring practice more precisely. And I think Conradi's, Tronto's, and Walker's language of care can shed light on relationships, responsibilities, and competencies, as well as on inequalities, power dynamics, and conflicts that might have caused dilemmas in the first place. Thank you very much for your attention.
Okay.
Thank you so much for your presentation. I really liked it. And I would like to add, in your conclusion you said we need a language to talk about care ethics. I would add we also need a public debate about care of ethics, which is missing right now in Germany. We do have a lot of emotional debates about assisted dying and end-of-life issues, but there is no broad understanding of what should be done at the end of life. And I think that's also the problem for the structural problem in hospitals. This is the underlying big issue, but it cannot be solved when there hasn't been a discussion about it and a broader understanding and more attentiveness from the government side towards the problem of end-of-life decisions. That's what I would say, and that was the comment. And the question would be, I was wondering about the ethic committees. Where do they get their education from? And who is actually in charge of what is an ethical issue? I mean, where do they get the idea of ethics from?
Mm-hmm. I would like to commend your comment because I think that's absolutely right. But still, you need language. You need the place. You need to be invited for these governmental consultations, like Nationaler Ethikrat, etc. And if you are invited, which is not yet the case, that nurses and people or palliative care physicians, not people from practice who really know what is going on in practice, then first we have to fight that they get that place there. And then the next step would be that they really represent the practices, the care practices, with an adequate language. You have to do both. They have to follow the discourse, the powerful discourse of ethicists and lawyers who are in these governmental committees, and at the same time bring in their perspective with regard to care. So, and at the time I did this study, I actually wanted to have the meso level, I call it. It's not about the interaction, but it's about the discursive space in the hospital as a unit of analysis to see what is going on. Yeah? And that would be another thing to do now, to see what is missing in all these papers now that are written about assisted suicide. Yeah, that would be a wonderful discourse analysis to see and what is missing. And now with regard to your question, we have in Germany the umbrella for further education and telling what should be done about it is the Academy of Medicine that is situated at the University of Göttingen. Of course, they do not define every ethical problem that is going to be discussed in ethics committees, but they regulate the kind of education that is accredited, that gets accreditation for clinicians. So, and they are the ones who have their focus, yes, and offer further education at different places in Germany. But in practice, it's a mixture. People attend classes that are offered by this umbrella organization at different places, and at the same time there are hospitals who do their own way and who mix it, who would always say who has competencies here and there, who would like to work on that, and then we have an internal way of education. Does that answer your question? Yes?
Yes, thank you. Michael Marsh, Wolfson College, Oxford. I wonder, in fact, whether public debate is useful. In England, as you know, we're trying to get a law through, or some people are, and we hear a lot about public debate, but it tends to be very polarized. Those that think that killing someone is of no consequence, and we have what you might call the theological pro-life group on the other side, rather like abortion, which brings up epithets which are not developed into useful arguments, like God gives, God takes, made in God's image, sixth commandment, and things like that. And we see in the papers that we've had good public debate, and I don't think we have had any public debate because I don't think people really understand what's going on and they get onto a bandwagon. I don't even think that Lord Falconer understands the problems that are involved in end-of-stage care, and yet he, as an unelected member of our House of Lords, is pushing through this legislation, whether you agree with it or not.
So your question is whether I think a public debate is...
Yes. What sort of public debate can one have that is going to have a useful outcome? I don't see that having happened in Britain, and that attempt in Britain has been going on probably since 1967, when our Suicide Act was changed so that the actual act no longer was punishable by whatever it was, if you survived. Whereas if you assisted, you are still liable up to 15 years imprisonment for assisting someone to kill. And this is and the problem here is that in England, we're having a debate based on that anomaly. Other people don't have that anomaly, so they're talking perhaps from different perspectives. But I'm very much interested in what your vocabulary of care would be in that respect as well. So a bit of a comment as well as a...
Yeah, a bit of a comment. Thank you very much. We are now getting into a really important discussion, I think, but she's very anxious to immediately react. That's okay, and I can comment then.
Just because you were asking about Britain, they actually just started research on end-of-life issues, and in the NHS, they have a new research group. It's end-of-life national care, and it was introduced by the NHS, and they will first meet in January 15 to actually gather research on that. So the public debate here in England actually has pushed something forward.
But nevertheless, the question still remains how to have a fruitful discussion without that polarization. Okay, please, would you comment on
I
it?
would like to comment on that, because at the moment in Germany we also have a public debate on assisted suicide. Yes, and the thing is that we have two groups, or maybe three groups: the liberal ones, who are quite liberal about it, and the ones who I would call the technical argumentation, saying this should be handled, 1, 2, 3, 4, 5 points we should discuss about, and then everything is fine. But it's not a dialogue, right? And you have this kind of answer. And the third group that is very strong now is the palliative care world. And the people have a different language. They have this care language going on, and they are getting stronger and stronger, and actually they are very much supported by the church at the moment. So having this going on, it's interesting in Germany. You can talk about palliative care, but it's very hard to talk about care. So, but palliative care can give you an entree to the discussion, because the people mean something very different when they talk about autonomy. They always mean care about autonomy, very different. So this is a chance. And I think a public debate is very necessary, but people have more and more to explain what they really mean when they talk about things, and you cannot do that in a, what I call, in that kind of technical and very pragmatic way. It needs the dialogue, and the people need to meet about it, and then they say, oh, now I really understand it, and now I'm convinced.
Okay, thank you. Perhaps there's no alternative for debate anyhow. Okay. I come to you.
Thank you very much. It was very interesting. I was for a while in an English version of a hospital ethics committee. So a bit of background on this. And all the work was very much, all the discussion rather, was very much along the lines you suggested, which it was new things, new technologies, new situations that really exercised people. But put that to one side. Firstly, a comment, which is I want to say something on behalf of autonomy, because it's a bit easy to override it. And I mean, as I remember this in the 1980s, one of the enthusiasm, what there was, for medical ethics, and the desire to incorporate it into medical education, which was quite a big thing in this country in the 80s. A lot of that emerged out of the tendency, or the perceived tendency, of doctors to neglect autonomy. In other words, they would focus very much on trying to do good for the patient or avoiding harm, so those two principles. Banging on about autonomy then seems to me to have been a very, very good thing, a very salutary thing to do, and I hope one wouldn't neglect it. And it still seems to be important that one should always bear it in mind. So that's my comment. And I have a question about your petite ethical problem as well. Again, thinking about when I was in the ethics committee, this particular hospital ethics committee, you'd need a filter for issues that would come to the committee. You just can't have every possible ethical concern raised by every member of staff coming to the committee. It's impossible. The committee will be swamped. So there does need to be some kind of a filter. And I wonder if you agree that there's a distinction to be made between the kind of ethical concern that should be resolvable at ward level and the kind of ethical concern that probably isn't resolvable at ward level and may need more of an organizational discussion. In other words, it goes to the ethical committee. And given that distinction, where does your petite ethical problem fall?
Yes, thank you very much for the 3 questions. I start with the last one. The best place for this petite ethical problems would have been an immediate group meeting between the ward sister at that time and the people around, and clarifying this from a very down to earth, what's the subject matter? Yeah. And the physician. So that, but sometimes it just happened that way. So it was a review, but still it would have been very good to discuss that on the ward. I'm with you. I would say all the time, if the people can do case analysis and ethical case analysis on the ward together, it's very close to the people it concerns. It's very good. You can never ignore that these ethics committees were invented to solve the problems on the ward. Mm-hmm. Because they failed on the ward to do that, which does not mean that the process should go in that direction, that on every ward people should be competent and organize time and space to do ethical case discussion. Yes? So this committee, yeah, I think so. I think it's very good, but this is also a didactical and organizational question. How can you do that people just implement it one step after the other? And maybe that's the committee members should do, that they should go to the board and discuss it there. Well, yes, and the filter. Yeah, and maybe then the filter is not necessary anymore when people can do that on the ward. The problem with the filter is that you easily distinguish between big and small problems, or problems to postpone and problems to discuss directly. What I think would be a fair answer would be here, if it is not going to discuss in the committee, where is it going to be discussed? Mm-hmm. And who will be the ones who are discussing it? Then the committee could say that, but not having this kind of dichotomy going on then. Yeah. And the first question, it's about the autonomy and the sorry?
More a comment than a question.
Yeah. Okay. Yeah, but you see, I see it from an historical aspect. You are absolutely right. It was in the 70s that paternalism was something people want to do something against, and then we had to turn to autonomy, and now people are starting to talk about relational autonomy and trying to balance it a little bit out. Yes. So at one point this is correct, but doing it this then in this kind of technical way, as I found out, using it in this sense, does not do any good, neither to the physician nor to the patient, I think. And dialogue is something you cannot just leave out in any case, I think.
So you mean there wasn't dialogue in the ethics committee?
No.
No?
No.
No.
Rarely.
Oh, really?
Rarely.
So dominated by a couple of physicians?
Yes.
Was it dominated by a couple of physicians? Or?
It was depending on the time, and it was depending on the day, so they were changing from Wednesday to Thursday and Friday, because, they have all these other works going on, so yeah, it's an organizational question rather than that people did not want to come. Yes. But with dialogue, I mean in any way that also with regard to paternalism, or if you want to focus on autonomy, it's still you need to have this kind of relation to the patient and see what is going on. Otherwise, it's getting very abstract.
You didn't have nursing staff on the committees, because this particular committee would ensure there was always senior nursing staff present.
Yeah.
So.
But our senior nursing staff the best people we have on an ethics committee?
They're the administration people, aren't they? I mean, they have been nurses.
Yeah.
Okay.
And it's who has the time to go to a committee meeting like that as well.
I go to the next question. It's for you.
Thank you. Hello. My name's Julie Winthrop. I work at the University of Southampton. Oh, sorry. My name's Julie Winthrop. I work at Southampton. And I have an anecdote and a question. Yeah. I teach student nurses. I am a health professional. And I was asked to step in unexpectedly to a session a couple of days ago with second-year postgraduate nursing students. So I told them about a conference we're running, which is loosely titled Everyday Ethics, which seems to speak to the mini problems you talked about. And we did big brainstorms. I had no teaching planned, so we did lots of discussion. They had the language, but it was not the language of ethics. And after this big brainstorm about all their problems in work and care, I asked them to pick out the ethical problems on the brainstorm, and they didn't see any. So we spent some time understanding them differently, which was quite liberating for them. And that was quite exciting. And I think there is a whole job of work to be done to relocate these kinds of ideas so that people who are doing those care practices every day can see them as political and organizational and managerial, and feel empowered that their work is of a high order and is important. And I suppose my question comes from that, which is, how can we address the organizational and managerial drive to locate care as the lowest part of our work and to attribute blame at the lowest part of the, lowest in terms of power, highest in terms of importance. And I don't know of a way other than having lots of time and lots of talking, which isn't available within practice itself.
Very concrete question. And so there is no other way than explaining very concretely what the matter is. So if a managerial answer does not meet the problem of conflicts in caring practices, you have to describe the caring practices in a narrative way and to defend it, how important it is. I don't think there's another way out to bring that. You have to see. You see, like, if there's a managerial answer and you see, I have just experienced something different, people need to say, but this is not what I experienced. I experienced something, I tell you the story, and I tell you that story now. And learning how to focus on what is really the issue that needs an answer can be very good done in classroom sessions with nurses, I think. So even when I teach nursing in the master degree, in the master level, they have so many conflicts of care practices still going on in their history. And I tell them, okay, now we've got the whole thing about different theoretical approaches in feminist ethics, for example. So what about your concrete practices? Do you remember a situation where you would say, oh, there was something going wrong, write it down, and we are going to see what is this about, or in which way can these approaches help and not help? So there's something, the two worlds for nurses, I think. They have this whole big world where they can participate talking with, but this is not their language, and it's not their stories.
We could do more in the classroom, because we're continually being told it should be done in practice, but I think we should do more.
Yeah.
That would be exciting, wouldn't it?
Thank you for your question.
Okay. I'll come to you.
Hi, thank you very much. It was very interesting. You know that I'm from Mexico, right?
Yes.
We talked about that yesterday. And I am drawn by these ethics of care theories and philosophy, and it's very attractive and very interesting. But I just don't know how to link it with our own context, and how to. I was thinking about Ken's questions about autonomy. And every time that I think about the ethics of care, and then I look at autonomy and justice, for instance, and I think, well, I'm dealing with issues of obstetric violence, for instance, and within a context in Mexico where justice is really absent, and you know, the violence and everything that is going on right now. So we are in the middle of this humanitarian crisis, and one thing, and if I think about the ethics of care and how to even suggest a language of an ethics of care without going through first this autonomy and justice principle. So basically my question is this a process? Is this something, can you actually talk about an ethics of care in a context where autonomy and justice has not even appear to be accomplished?
Having the ethics of care in mind, and still are confronted with everyday life situations and political issues, legal issues, you think that falls apart, still means the question that is raised in a very concrete situation, you would say, what would be a care ethicist now ask first?
Mm-hmm.
Yes? So it has to do with, I'm just focusing now on something. It has to do with, have we done everything to be in a good relation? And if not, why is that so, and what can we do about it? So I can only answer this from seeing that you have a very concrete situation, and then asking yourself, what would be the question from a care ethics perspective, which does not mean that care ethics can always be the first way to deal with it. Yes, it cannot be the answer for everything, especially when your context is very different. But having it in mind, it might be on a special level, it can be helpful. Because your question is rather from the macro perspective, I think. Yes? On the macro level, then usually ethics of justice and allocation problems, etc., usually are on the forefront. And the ethics of care might then, at a certain question that is coming also in, might then come in. Yeah? You see, I can only answer this in that abstract way. You are also rather abstractly pointed out the problem. I can see it, but it's very difficult now to answer it very concretely. So if you would give me a special example in your professional work, we could see what would be the question from an care ethical perspective.
Do you have an example like that? No?
Yeah?
Yeah, okay.
Yeah? Is that helpful in any way?
Yeah, well, yes and no. The basic example will be that. I mean, the basic example will be cases of obstetric violence, which are not in any way, there is not a question that there is an ethical issue there, but then an ethical issue that should attend first to justice and autonomy, or forced sterilization, of course, is also the obstetric violence. But so basically is how to, and I'm telling you this because I just wrote a column about the ethics of care about 2 weeks ago, because I was so happy with the seminar that I just, I found myself speaking about it in a column. And I, you know, the response that I received was like, it was basically, you know, how romantic that sounds, but just wake up. This is not something that we can even imagine at the moment. And my argument was, well, there's just not enough to talk about justice. I'm not saying that we shouldn't be talking about justice, but it's just not enough. There are things that we're not reaching.
Yes. Okay.
But it's still, I have that sense of how to approach it and how to deal with it in this context of just crazy violence.
Perhaps we should address the question in the next lecture. So thank you for the question.
Yeah, but maybe when you just when you were talking about this, you see how important then it is to clarify that especially care ethicists in the 90s have raised the question to talk about the conflicts, the power relationships, and inequalities. And then you might want to look at these theoretical approaches, what kind of examples they use. There is this wonderful article by Margaret Urban Walker about crime and the ethics of care. Yeah, the vicious circle of crime and the answers by the ethics of care. So that might be helpful then to see that, and not leave out that care ethicists thematize especially these categories.
And Virginia Held wrote about terrorism and
Yes,
ethics of care.
also.
So there is a political linkage.
Mm.
Come to France.
Just adding to what you were saying, Helen, about the relation, the question of the ethics of care would be what are the actual relations that you can rely on? And with regard to Mexico, not that I know much about it, but we did follow the whole scene with the disappeared students in Mexico. Where is the actual community? There is a community there, even if there is a strong case of injustice and the situation is full of injustice, but I think the ethics of care would ask for where is the actual community? Where are these people linked together and related together, and how is it, what is the power of this actual community? Instead of starting with, so I do think the ethics of care has nothing of romanticism in it, really not. That's not the way it is was developed by the first generations, and it's still not. It is very practical when looking at a disordered community, as some of the examples in Mexico point out.
Do you want to respond about the communities? No? Okay. I hope we can come back to that in the next two lectures. It's critical question. Is it just romantics, or do we have some political, ethical instruments? So it's an essential question. Thank you for your question. I think the last question is for you.
Okay, except that you had your hand up earlier.
I come to you, then you have the last question.
I don't have a question. I just have a few comments based on my experience of some decades ago now of being a palliative care nurse.
Yes.
And I very much heard what you said about the impact of hierarchy, which means that both women and nurses, who still are majority women, are the least likely to express their ethical concerns. They will have the least confidence to do that. I fear that that is relatively unchanged. The other thing is, I was very interested in your three groupings of in Germany of people concerned, and that palliative care experts are sort of on one side of the divide. And my experience was certainly that one of the issues is that palliative care is sometimes equated with pain control, as if that's the only issue. And I think that a great deal of expertise, that there is now a great deal of expertise in pain control, although it still is not as widely known as it should be, but that's not the only issue facing people at the end of life. And I felt, in my experience, I worked in a leading hospice which was exemplary in many ways, but but that while pain control was very well managed, other issues were not so well addressed. Yes. And I think that often there's a tendency to think that that is the sole issue that makes, for example, the advocates of palliative care would say good pain control makes assisted suicide unnecessary, which is oversimplifying the case.
Thank you.
You want to comment on it, or?
I mean, there's always an ups and downs to see what people want to focus on with regard to palliative care. At the moment, I think 3 years now, they have now the turn to how important spiritual care is it's not so much looked at as it is with pain control. But now they have to turn in Germany and look at spiritual care. And then for a while, social care was very important. So what you can see is, again, when you look at history, since the 80s, they are always trying to focus on something, but not doing everything at the same time, which actually means what is palliative care is about. So we are facing the same problems. It's just also a question of time and having the personnel and the competence together. Yes. Yeah. Thank you for your comment.
Thank you very much. Helen, we want to thank you for a very, very interesting session. And of course, there are still many questions to be asked and to be answered. So please take a few minutes if you want to ask her a personal question. So, and with that, we conclude. So see you next week. Thank you.
Thank you. Thank you.